Hey everybody, it's Dr. Dave Psychiatry. Thanks for coming to the YouTube channel today. Reminding you that if medication fixes your problem, that makes it a medical problem, not a mental problem. Not saying that there's not mental stuff out there, not things that you don't have to talk about, relationships, emotions. But if medicine fixes that, that makes it medical, not mental. That's important for everyone to understand. Today I'm going to answer the question, hey Dr. Dave, what is Abilify? Abilify is a medication that I use a lot. It's been around for a long time, since, in my memory, since the 2000s. And it's generic now, which means it's not very expensive. And the generic name for it is aripiprazole. So if you're taking Abilify, if you have friends or family taking Abilify, or if you're thinking about taking Abilify, this video is for you. Now, obviously on the internet, there's the manufacturer website, there's the Mayo Clinic, there's the medication-related websites that you can go to. So the internet, you can read all of the warnings, all the package information, everything is out there. So as usual, these videos are more about how I think about Abilify and how I use it, and hopefully that's helpful to you. And the long and short of it is, Abilify, even though it is officially classified as an atypical antipsychotic, which means unusual, atypical, and antipsychotic, used for what people would call crazy, psychosis, which would include delusions, hallucinations, and conditions like schizophrenia and bipolar disorder when psychotic features are there. I simply think of Abilify as a dopamine suppressor. So in my categorization of how I think about medicines, obviously in the other videos you've seen that there are medicines that boost serotonin, there are medicines that boost norepinephrine, there's medicines that boost GABA, and there's medicines that push down or suppress dopamine. And when dopamine excess is a problem, then that can cause overthinking. Dopamine I consider to be, in the majority, to be a thinking chemical. So too much dopamine equals too much thinking. And so medicines that push down dopamine are useful in patients that think too much. Now, sometimes those conditions are related to the psychotic things that I just mentioned before. And officially, Abilify is FDA approved for treatment of, schizophrenia and bipolar disorder with psychotic features. It's also officially approved as an add-on for depression. So we'll talk, that's really the main way that I use it. Also officially approved for irritability with autism and Tourette's syndrome in kids, which I don't see a lot of kids, and I haven't treated a lot of Tourette's in children, so I don't have a lot of experience with that. But Abilify is a tool that I routinely use when I have a situation where a patient needs to think less, worry less, and experience less agitated thoughts with the background concern being that they're making too much dopamine. So as an add-on for an antidepressant, and whether this is off-label or on-label, the point there is that people that have brain chemistry problems, they often don't just have one single brain chemistry problem. So it's very common that you'll see the combination of the shortage of serotonin, which causes depressed mood, low interest, low energy, hopeless, helpless, can't concentrate, thoughts being dead, and also a dopamine excess, causing them to think too much, worry too much, can't shut my mind off. We learned this a long time ago with Zyprexa, olanzapine, which was actually developed by the same company that developed Prozac, fluoxetine, and that combination of a serotonin booster, Prozac, plus a dopamine suppressor, Zyprexa, was so good that they actually put it in the same product, and that product was called Symbyax. It was a joint product with two things in one capsule, and that Symbyax product really was marketed, tested, and used for the treatment of what's called treatment-resistant depression, acknowledging the fact that serotonin boosting is helpful sometimes and additional dopamine suppression is required. So Abilify is one of those medicines that I use in that way a lot, and I believe it's FDA approved for that. You can double check that. But it's something that I do routinely when someone can't shut their mind off in the throes of depression. The thing about Abilify that's interesting is that it's got a little different side effect profile than Zyprexa or Seroquel or Perfenazine. All those three medicines you take at nighttime. Abilify is a medicine that you take in the morning. It is typically more like a cup of coffee than it is like a sleeping pill. So patients that take Abilify typically take the Abilify in the morning, and I find that most times people say, yeah, it's a little activating, it's something that wakes me up a little bit, and they're fine with that. If you're a rare person that's taking Abilify and it makes you sleepy, then certainly you can take it at bedtime. It doesn't change the therapeutic effect. But most people take Abilify in the morning. And another thing that I discovered with Abilify, having used it since the 2000s, is that I generally don't start with Abilify when I'm doing dopamine suppression. People that can't shut their mind off, and often that's can't sleep, and you've probably seen the video on Seroquel, quetiapine, or I've done videos on Zyprexa. There's other tools, Risperdal, perfenazine, tools that I use routinely. The Abilify is a medicine that when I first started using it, I had some concerns because more people got agitated than I wanted them to. Now, I don't know why that happened, but when you first get a medicine and you're using it for the first time, you see side effects and you pay attention. The first thing that I noticed with patients that I had immediately started on Abilify just right out the gate, a lot of them felt that it made them jittery, jumpy, too much, felt like they were maybe overdone, and they didn't like it. So my initial impression when Abilify first hit the market was it wasn't a medicine that I was going to use very much. Well, in troubleshooting brain chemistry, there's a lot of times that you have to, once something doesn't work, you got to do the next thing and the next thing and the next thing. So I sort of discovered in my practice is that patients who do well with Zyprexa or Seroquel or Risperdal or Latuda or Geodon, they're not going to need a trial of Abilify. But patients that don't do well, and typically for me it's a trial of at least one or two, if they don't do well with excess sedation on Zyprexa, and then you try them on Risperdal and they don't do well with excess sedation on Risperdal, and then you try with Latuda or Geodon and they don't do well with excess sedation, that particular patient that doesn't do well with the excess sedation of those medicines I just mentioned, a lot of times will do well switching to Abilify. I can't explain it. I don't know why, but it's an observation that sort of makes me hold on. When I've got a new patient that's not taken any dopamine suppressor before, a lot of times I will try the evening dopamine suppressors, the more sedating dopamine suppressors, before I try the Abilify. And if they fail in the fashion I just described, then a lot of times they will actually do very well on Abilify. Abilify comes in a pretty wide dosage range. I typically don't use the 2 milligram. They do make a 2 milligram. My dosing notches for Abilify are 5, 10, 15, 20, 30. You do actually have the capability of going all the way up to 30 if you want to. Beyond 30, even though I don't think the pharmacies would fill a prescription or insurance would pay for more than 30, I would say if you've gone to 30, you've given it the best try that you can. And typically the dosing notches on those, I would run at least for 2 weeks. And a lot of times I would ask for a month if I had to just make sure that 5 wasn't working or 10 wasn't working or 15 wasn't working. I'd go to 20 or 30. The truth is, a lot of times people feel better quickly. And if you're feeling a lot of clinical urgency and if you need to feel better quickly, it's not unreasonable to use Abilify and make a dosage change within a couple of weeks, within 2 weeks. No, I would not do it at 1 week. I'd always give it at least 2 weeks. As far as risks and precautions, you can review that on the internet. There's obviously the same prohibitions, or not prohibitions, but concerns that we have with dopamine, with movement disorders. We don't know what causes movement disorders in patients that have dopamine excess. I've said before in a lot of videos that my sense is that there's something disturbed with the dopamine system. So a lot of people that have movement disorders with the dopamine-related medicines, well, they have a dopamine disturbance of some kind lingering in the background. There's the concern that if we give patients medicines, and you can see this on the internet as well, that if we give patients that have agitated dementia, that they might be more at risk of dying when you take Abilify or medicines like Abilify. The problem there is that if they're agitated and with dementia, a lot of times all the medicines that we use, or most of the medicines that we use, can run that risk. And so there's always the decision of, do we try to use a medicine to help people to alleviate their suffering? And is that a good idea, and is it worth the risk? But obviously, caution with your doctor, discussing those things as you need to before you're thinking of taking it, or if you have a loved one who's taken the medicine. The balance is always, are we trying to help the patient, or are we putting them at excess risk? And that's something that patients and their families have to decide. So Abilify, like any other medicine that we use, it has its risks and it has its benefits, and you have to be aware of them. The long-term risk of movement disorders with tardive dyskinesia, abnormal involuntary movement, stuff like things of that nature that I've talked about before. Certainly that's something that has to be considered. But in general, the modern, what we call the atypical antipsychotics, because they are modern, in general, those medicines have markedly less risk of abnormal involuntary movements long-term, which makes them far and away better than the original versions that we're using, like Haldol and Prolixin back in the 70s and 80s. Abilify is a great medicine. I use it a lot. It helps a lot of people. Obviously, if you take a medicine and you don't like how you feel, then you got to stop it. That's part of the trial and error process. But as far as knowing your stable of dopamine suppressors, Abilify, aripiprazole is a good one. So if your dopamine is here and needs to come down here, then that's something you can talk about with your doctor. I'm Dr. Dave Psychiatry. Thanks for coming to the channel today. We'll see you again soon.